Dr. My dear friend and class fellow, for inviting me on this great meeting. It has been, I've heard lots of good news and positive reviews about it. So I'm going to talk about gastroesophageal reflux disease, which I think is a very common problem, regardless whether we are in UK or Pakistan or even in other European countries. I'm sure I don't need to go through the definition of gastroesophageal reflux, but just to mention that reflux disease is defined as symptoms or complications resulting from the reflux of gastric contents, not only in the esophagus, but also beyond the esophagus, oral cavity, including larynx or lung. As I mentioned before, that GORD is a very common problem worldwide. And this is a US study which basically showed that the prevalence of gastroesophageal reflux disease is in the range of about 20 to 30% in US and same in UK. As far as Pakistan is concerned, I came across one study which was published about 13-14 years ago in 2005, which showed a prevalence of about 25 to 30%. I don't know whether there's any up-to-date data available or not. So gastroesophageal reflux disease, although a very common problem, has got a significant impact on the quality of life, as shown by this well-being index. And as you can clearly see, that compared to other common conditions, it has got significant impact on the quality of life of our patients. Now we all know that there are several factors which can predispose to reflux, which include increased intra-abdominal pressure in the term of carrying extra weight around the belly, inadequate cardiac sphincter for anatomical reasons which reduce the tone, i.e. hiatus hernia or esophageal dysmotility, poor esophageal peristalsis, smoking, alcohol, fat, pregnancy, obesity, big meals, and then there are certain drugs like tricyclic antidepressants, anticholinergic and calcium channel blockers, which can also increase reflux. As far as the clinical presentation of GORD is concerned, the commonest symptom which the patient presents with is heartburn and acid regurgitation. But then we see a significant proportion of patients in our clinical practice which do not present with these classical features of GORD. And that include things like atypical chest pain, presenting with supraesophageal symptoms like laryngitis, asthma, sinusitis, chronic cough, which is a very common problem, aspiration pneumonia, and things like tooth decay. As far as the pathophysiology of GORD is concerned, there are several factors which contribute to it. And we can start with the top, including impaired acid neutralization by saliva and bicarbonate, impaired esophageal motility, as I mentioned before, inappropriate relaxation of the lower esophageal sphincter, presence of hiatus hernia, and then things like delayed gastric emptying and gastroparesis, which is a common problem in patients with type 1 and type 2 colitis. Lifestyle factors I've already mentioned, that obesity, smoking and physical activity can provoke symptoms of GORD and can make it worse. Then the medication which I mentioned before, and just to list those medications, because we do come across in our clinical practice in patients who have got resistant symptoms of GORD, which are not improving with the usual therapy, and then when you go through their drug history, you find that there are certain medications which might be aggravating their symptoms, and calcium channel blocker seems to be one of the commonest ones. So drugs like beta-adrenergic agonist, theophylline, anticholinergic, tricyclic antidepressants, diazepam, calcium channel blockers, and then bisphosphonates is another medication which we find very commonly in UK, which is used for the treatment of osteoporosis, which can increase the symptoms, aggravate the symptoms of gastroesophageal reflux disease. Then, as I mentioned before, the second commonest symptom which we come across is patients presenting with cough, chronic cough. And it's not uncommon for respiratory physicians to refer these patients to the GI clinic, where they've seen a respiratory physician with chronic cough, have had extensive investigation and they haven't found the cause, and they think that the cough might be related to underlying reflux. And there are two possible mechanisms for that. So one is the gastric refluxate, which aspirates into the lower respiratory tree and triggers the cough. And the second plausible mechanism is that the gastric refluxate, through the stimulation of the vagus nerve, esophageal droplet transfer transmission via the cough center triggers the cough response. And it could be a very difficult condition to treat. Phenotypically, we can classify GORD into 3 categories. So one is what we call NERD, which is non-erosive reflux disease, which is by far the commonest phenotype of gastroesophageal reflux disease we come across in clinical practice. So 60 to 70% of our patients, they present with GORD symptoms, but when you do an endoscopy, you don't find any abnormality. And that does not mean that they haven't got reflux. They have got reflux, but they come into the category or subcategory of what we call NERD. 20 to 30% of these patients will have erosive esophagitis, which makes our life very easy. And then 6 to 10% might present with what Barrett's esophagus, which could be their first presentation ever to the GI clinic with reflux symptoms. Symptoms I've mentioned before include heartburn, regurgitation, chest pain, impaired quality of life, atypical symptoms, supraesophageal symptoms, and things like burning in the mouth and tongue. These are the symptoms as patients with erosive esophagitis and Barrett's esophagus, and that's very important to know. And the severity of the symptoms cannot predict the subtype of the GORD into which a patient falls prior to endoscopic examination. So if you say that patient presenting with, we have seen patient presenting with severe reflux symptoms with a plumb normal endoscopy, or patient with presenting with very minimal symptoms, and when you do an endoscopy, you find severe esophagitis, stricture of the esophagus, or even Barrett's esophagus. Endoscopically, the commonest classification we use is the Los Angeles classification of esophagitis, or the LA classification in short. And that can range from normal squibocolumnar junction to elevated esophagitis, elevated esophagitis, things like complications of gastroesophageal reflux, including the stricture, which can be seen in this endoscopic picture. And then last but not the least, one of the dreaded complications for the patients, Barrett's esophagus, which can eventually lead to gastric cancer. Now, Barrett's esophagus is an interesting condition, and it is well recognized that any prolonged acid reflux, Barrett's esophagus is associated with prolonged acid reflux, which is shown clearly in this study. And also, it's important to note that the prevalence of Barrett's esophagus increases with the duration of reflux symptoms. So the longer the duration of the reflux symptoms, increased chances of having Barrett's esophagus in endoscopy. We are often asked that can Barrett's esophagus occur in asymptomatic patients? And the answer to that is yes, as shown by this study, where an endoscopy was done in about 1,000 patients, which was scheduled for a colonoscopy, and about half of them never had heartburn. But what they found was that Barrett's esophagus is relatively common in persons aged more than 40 years with no prior endoscopy and no symptoms. And long-cycle Barrett's esophagus is very uncommon in patients who have no history of heartburn. That's one of the reassuring facts about Barrett's esophagus and reflux. As I mentioned before, that one of the dreaded complications of reflux in Barrett's esophagus is esophageal adenocarcinoma. And if you look at the literature, what we quote to the patients in terms of the absolute risk of developing adenocarcinoma in Barrett's esophagus vary a lot depending on which study we look at. However, the true risk is estimated at 0.5% per patient year. Now, the precursor of cancer in Barrett's esophagus is dysplasia. Low-grade dysplasia can occur in about 7.5% of the patient with Barrett's esophagus, and about 3% can have high-grade dysplasia. We all know, I won't go into the details because that would need another separate talk to go through the Barrett's esophagus, but the dysplasia must be confirmed. High-grade dysplasia must aggressively be looked for prevalent cancers. Screening and surveillance intervals is a totally different debate, and we can spend hours and hours on that. The management options of high-grade dysplasia in Barrett's esophagus include sphinctectomy, ablation, and endoscopic esophageal resection. So just a brief mention of that. So once we have diagnosed Barrett's esophagus, reflux, the problem is how to treat these patients. And And let's present a real life scenario that a 35-year-old woman, which I think will be a very common presentation, presents to her primary care physician because of 6-month history of heartburn. She's very fit and well, apart from history of chronic migraines. And she has got no, what we call red flag symptoms, things like dysphagia, odynophagia, or weight loss. She experiences symptoms several times a week, and usually during stressful days at her job as a high school teacher. So what would we, can we just have a vote from the whole audience? What would they do with this lady in terms of treating their reflux? So the initial management of heartburn consists of antacids and lifestyle changes, which I think are extremely important and are overlooked by the physicians as well as ignored by the patients. And they play an extremely important role in the management of these patients. A starting point would be a H2 receptor antagonist. Then the second step would be a standard proton pump inhibitor. If the patient's symptoms do not improve, then I think the next step would be a high-dose proton pump inhibitor, which could either be a continuous therapy or on-demand therapy depending upon the severity of the symptoms. And then would come the stage of what we call endoscopy or PS testing, followed by therapy based on results. So as I mentioned before, that lifestyle modification remains the cornerstone of any therapeutic intervention in patients with GORD. It is commonly overlooked by the physician and not followed or ignored by the patients. And weight loss is extremely important in treating these patients. I always advise them to stop smoking if they are smoking, or at least cut down on their smoking. Alcohol, I don't know how much of an issue is that in Pakistan, but certainly in UK, it's a significant problem, and we strongly advise our patients who drink excess amount of alcohol to cut down on their alcohol intake with a view to stop it. And then significant proportion of patients report that tobacco, chocolate, carbonated beverages, onion tomato sauce, I mean the list is long, can aggravate their reflux symptoms. And what I basically tell them, because there is no clear evidence or quality trials providing clear evidence for the benefit of avoiding these food products, what I say to them is that if they've got any specific dietary factors which might be triggering their reflux symptoms, to avoid them or to stop them. The advantage of proton pump inhibitor therapy as a starting point is that it functions both as a diagnostic and a therapeutic trial with a sensitivity about 68 to 80% as defined by abdominal pH testing and endoscopy. However, the disadvantage is that it can have a placebo effect and may be falsely positive and does not actually make a true diagnosis of gastroscopic reflux disease. What about the indication of additional investigations? So if a patient presents with certain symptoms, then I think we should scope these patients first before putting them on proton pump inhibitor therapy. And those symptoms include atypical history, symptoms that are frequent and long-standing and do not respond to standard therapy, because majority of these patients have already tried proton pump inhibitors either by their GP or using the PPIs of their partners or their husbands or wives, and they haven't responded to the treatment when they come to the clinic. And then it's extremely important for the physicians, both in the primary care and the secondary care, to be aware of what we call these red flag symptoms. That if the patient presents with these symptoms, then they should definitely be referred to an endoscopy first, rather than just going on to empiric PPI therapy. And those symptoms are severe dysphagia or dysphagia, weight loss, bleeding, anemia, hematemesis, mass in the upper abdomen. We've got nice guidelines for the urgent referral for suspected GI cancer, which is really helpful in terms of deciding whether these patients need an endoscopy before putting them on to empiric PPI therapy. And they basically do exactly the same thing which I mentioned before, that if there's any history of dysphagia, any history of dyspepsia associated with weight loss, proven anemia or vomiting, dyspepsia in a patient aged 55 years or more with at least one of the following high-risk features, dyspepsia combined with at least one of the following known risk factors, i.e. family history, parasitic hepatitis, pernicious anemia, previous spectacles, surgery, known dysplasia, trophic gastritis, intestinal metaplasia, jaundice of abdominal mass, should be referred to the secondary care for investigations before starting on empiric PPI therapy. So, the patient which I mentioned before, the 35-year-old fit and well lady, was seen by her primary care physician, and she was put on H2 receptor antagonist and was recommended some lifestyle changes and intermittent antacids. She returns a month later with no change in symptoms, and she's put on a high-dose PPI, or sorry, once-daily proton pump therapy, and is referred for an endoscopy. The endoscopy is normal, which, as I mentioned before, the 60 to 70% of these patients will have a normal endoscopy when they're referred to us. But she's still symptomatic. So what shall we do? Increase the proton pump inhibitor therapy, and there is quite a bit of evidence in the literature that if you increase the dose of the proton pump inhibitor therapy or use what's called a split dose PPI therapy, that provides a better acid control compared to once daily PPI. Refer for endoscopic treatment, which I think would be a bit too early, or surgical treatment, and perform pH therapy in a subgroup of patients, which I would definitely consider. But before doing that, I think we need to ask the question that why patients fail PPI therapy. And the commonest cause is patient non-compliance. So they are either not taking the proton pump inhibitors or they are not taking it appropriately. And there's persistent esophageal acid exposure, and then the large hyperthermia, non-acid reflux. And last but not the least, that the diagnosis is not right and we need to reconsider our diagnosis. So the treatment goals for GORD is that we should eliminate the symptoms of the patients. If they've got esophagitis, to heal that esophagitis, manage or prevent complications, and maintain remission. Anti-reflux surgery has got a definite role in the management of GORD, but the outcome of anti-reflux surgery is highly dependent on the skin's experience of the surgeon, and the surgery does not always end the need of anti-secretory therapy. So I think that's a very important point you need to mention to your patients, that although I can refer you for surgery, but even after surgery, about 30% of the patients would still require PPI therapy to control the reflux symptoms. The patient must understand that before they are referred for surgery. The common procedure is laparoscopic nasal fundoplication, and then there are certain predictors which I don't want to go into the detail of. And as I've mentioned before, that surgery does not mean that the patients are cured. A significant proportion will still require proton pump inhibitors. And another important point you need to mention to the patients when you refer them for surgery is that surgery does not prevent NES cancer. So they're still, at risk of developing esophageal carcinoma if they've got underlying Barrett's esophagus. Now I'm sure you'll be aware that in the literature in the last few years, although PPI therapy has been used for several years, the literature has been stormed by publications, and they're all population-based studies on the side effects of proton pump inhibitor. Which include things like nutritional deficiencies, magnesium, vitamin B12, increased risk of gastroenteritis, microscopic colitis, increased risk of ischemic heart disease, chronic kidney injury, and dementia. And I think it's very important that you should mention this to your patients before putting them on long-term PPI. Recent data has demonstrated increased incidence of chronic kidney disease dysfunction due to acute incision nephritis, especially in patients taking high doses of PPI. More recently, PPIs have been shown to increase the risk of dementia, but as I mentioned before, regardless, patients should receive the lowest dose of PPI that controls the symptoms, and the need for chronic PPI treatment should be evaluated on a regular basis, and alternative options to chronic PPI therapy should be sought out in patients with high risk of PPI-related adverse events. So, what are the take-home messages? GORD is a very common disorder. It can be managed effectively in a large number of patients with combination of lifestyle medications and appropriate medical therapy. Managing refractory GORD, which can be seen in up to 40% of the patients receiving PPI once daily, can be challenging. The best initial approach is optimization of the PPI therapy and making sure that the patients are compliant with their treatment. A careful history and use of investigative tools can help identify the contributing factors for PPI failure and beware of alarm symptoms. In patients with residual reflux, medications like H2 blockers, prokinetics, and beplofen may be used. In those patients with functional heartburn or reflux sensitivity, neuromodulators from an integral part of the therapeutic approach. Surgical fundoplication for GORD is still performed, but the rate of utilization has been markedly decreasing in the recent years. And endonuclear therapy is just a thing to mention, things like strata and esophagus TIF providing efficacious symptomatic control in a subset of patients and serve as a good alternative to medical surgical treatment. Thank you.